Okay, good morning everybody. I hope there is no problem with sound and everybody hears me. Today we are going to speak about such topic as acute and chronic sinusitis. It's one of the most spread ENT pathology in ENT practice, and of course you need to know what to do with these diseases. Do you hear me? Everything okay? Okay, let's continue. So, what is sinusitis? Sinusitis is an inflammatory disease of paranasal sinus mucosa. 5% of population suffer, but I think that real percent is high because a lot of persons don't go to the doctor when they have symptoms of sinusitis. Takes the third place in the ENT disease structure, make up to 36% of stationary and 16% of outpatient ENT organ pathology. It may lead as complications to infections of respiratory ways, lower respiratory ways and lungs, and to be a reason of orbital and intracranial complications. Everybody remember that all paranasal sinuses are divided on anterior group and posterior. Yeah. Anterior group is maxillary sinus, frontal sinus, and anterior ethmoid cells. And posterior group have their openings in the sphenoethmoid recess and superior nasal meatus is posterior cells of ethmoidal labyrinth and sphenoid sinus. Yeah? And all sinuses of anterior group are drained into middle nasal meatus. This topic is not full without understanding the term of osteomeatal complex. Yeah, osteomeatal complex is a part of ethmoid bone and represent the system of courses and apertures in the area of anterior part of the middle nasal meatus. If we look on this picture, so the structure of the osteomeatal complex is presented here. So what structures form osteomeatal complex? Yeah, it's uncinate process. Yeah, it's the middle turbinate. Yeah, maxillary ostium, bulla, ethmoid bulla, and hiatus semilunaris. Yeah. And also infundibulum. here, or on this picture. Yeah, what we can see here this semilunaris zone where anterior ethmoidal drain, place where maxillar sinus drain, yeah, bulla ethmoidalis, middle ethmoid cells. On this slide, you can see the direction of mucociliary clearance in paranasal sinuses. Yes, you remember that mucociliary clearance is the main mechanism of protection and evacuation, the protection of nasal mucosa and evacuation of different pathological agents from nose and paranasal sinuses. Yes, so as you can see, so it's maxillar sinus, it's frontal sinus. In each case, the direction of mucociliary clearance is directed to the natural ostium. Yeah, here, and of course it's this very energy dependent process, because you can see that, for example, from maxillar sinus, the direction of mucociliary clearance is move upward, yeah, and it need a lot of energy, yeah. So this transport is very sensitive to energy deficit. If we speak about frequency of paranasal sinuses inflammation, we can see that on the first place is the inflammation of maxillary sinus. Yeah, it's maxillary sinusitis or enteritis. Yeah, here we can see maxillary sinus. Then on the second place is inflammation of ethmoid labyrinth, ethmoiditis. But you must remember that on childhood, at children of younger age, the ethmoid cells inflammation is met more often than maxillary sinus, and it connected with this situation when in childhood maxillary sinus is not developed well, yeah, but only sinus when with what type of sinuses child is born is ethmoidal sinuses. On the third place, frontal sinus frontitis, and on the fourth place, sphenoidal sinus or sphenoidal sinusitis or sphenoiditis. The situation when few different sinuses are damaged, for example, maxillary sinus from the left side and frontal sinus from the right side, or maxillary sinus from and frontal sinus from one side, it's polysinusitis. We use term. If all sinuses on one side is damaged, it will be hemisinusitis, as on this picture. And if all sinuses are involved in pathological process, it will be pansinusitis. So as we how we spoke about, yeah, mucociliary clearance is very sensitive to different conditions. And what are the conditions for normal functioning of paranasal sinuses? Yes, it's constantly open discharge aperture. So it means that if we look on the maxillary sinus, that this passage must be open, yeah, and maxillary ostium also must be open. high efficiency of mucociliary transport system. The secret from the maxillary sinus is deduced and filled with new for 20 minutes. Yeah. So it means that there must be no any problems for blocking of mucociliary transport system. And the third condition is the high oxygen content in paranasal sinuses. And also back to this, for example, slide, for high concentration of oxygen in paranasal sinuses, the ostiums must be open. So, etiopathogenesis of sinusitis. So, as it is inflammation, so it must be pathological agent that cause this condition. As usual, as any disease, almost any infectious disease, it can be bacterial, viral, or fungal etiology. Of course, usually everything is started from viral infection, then maybe bacterial, and in some cases fungal. So in acute sinusitis, the monoflora is more often. So only one agent is etiological factor. Yeah, it may be streptococcus, staphylococcus, pneumococcus. It may be gram-positive or gram-negative flora, and sometimes chlamydia. At chronic forms, almost often mixed flora can be revealed. It's maybe coccus, sticks, pathogenic fungus, and its combinations. So, why acute process may transform to chronic process? Maybe as general, so and local factors. Yeah, general, it's decrease in reactants of the organism. Local immunity decrease, immunoglobulin A deficiency, allergy, resistance of flora to antibiotics because of irrational usage of antibiotics, and mixed flora. Also, there are a lot of local factors. Yeah, so if we see if the patient has break of paranasal sinus draining, yeah, it means that mucus is not effectively evacuated from paranasal sinus. It leads to penetration of infections into mucus of paranasal sinuses and development of sinusitis. Also, what it may be. So, any things, any conditions that lead to blocking of natural osteum, yeah, lead to possible development of sinusitis. So, it may be deviation of nasal septum, it may be hypertrophy of nasal turbinates, yeah, different deformations of processus uncinnatus, yeah, bullet medalis enlarging. It may be adenoids, vasomotor rhinitis, narrowing of paranasal sinus, osteums, defects of mucosa of paranasal sinuses. So how infection can spread, can appear in paranasal sinuses. Of course, the most common way is rhinogenous, yes, through the nose and nasal cavity, but also maybe hematogenous, traumatic, and odontogenous. Yeah, and pay attention to this form of sinusitis because it takes up to 40% of chronic maxillary sinusitis. So, what is rhinosinusitis? Rhinosinusitis is a significant health problem which seems to mirror the increasing frequency of allergic rhinitis, and which results in a large financial burden on society. Rhinitis and sinusitis usually coexist and are concurrent in most Indian adults. Thus, the correct terminology now is rhinosinusitis. No, it's quite understandable because if we are speaking about rhinogenous as the main way of spreading the infection, it is very difficult to imagine that infection can damage only paranasal sinuses without mucus of nasal cavity. So most guidelines and expert panel documents now have adopted the term rhinosinusitis instead of sinusitis. The diagnosis of rhinosinusitis is made by a wide variety of practitioners, including allergologists, otolaryngologists, pulmonologists, primary care physicians, pediatricians, and many others. So you must remember that firstly, and in most cases, such patients will be treated in primary care physicians or doctors of family medicine. So you need to diagnose this situation, to know how to treat, and to know what are red flags in the development of this disease. So, clinical definition of rhinosinusitis in adult. So, rhinosinusitis in adult, please remember this or write anywhere this definition, because in this definition is the main information about this disease. So, rhinosinusitis in adult is defined as inflammation of the nose and the paranasal sinuses, characterized by two or more symptoms, one of which should be either nasal blockage, obstruction or congestion or nasal discharge, anterior or posterior nasal drip, facial pain or pressure, reduction or loss of smell, and also endoscopic signs of nasal polyps or mucopurulent discharge primarily from middle meatus, and or edema or mucosal obstruction primarily in middle meatus, and or CT scan changes. Clinical definition of rhinosinusitis in children is most the same. Yeah? So it is defined as inflammation of nose and the paranasal sinuses characterized by two or more symptoms, one of which should be either nasal blockage, obstruction, congestion, or nasal discharge, anterior, posterior nasal drip. Facial pain, pressure, cough. If comparing with the previous definition, in adult it's reduction or loss of smell, in child it's cough. And either endoscopic signs of nasal polyps and or mucopurulent discharge, edema or mucosal obstruction, and CT scan changes. So also remember this duration, because it depends what form of sinusitis you diagnose in your patient. So acute, it's less than 12 weeks with complete resolution of symptoms. Chronic is more than 12 weeks without complete resolution of symptoms. Sinusitis classification, of course, due to localization, maxillary, ethmoid, frontal, sphenoids, hemosinusitis, pansinusitis, and their combinations. Due to morphofunctional changes, yeah, acute it's catarrh-purulent necrotic, chronic catarrh-purulent hyperplastic fibrous cystic mixed forms, and vasomotor, allergic and non-allergic. Due to way of spreading the infection, it's rhinogenous, adaptogenous, traumatic, and on the character of pathological agent, it may be viral, bacterial, fungoid, and mixed. In the case of acute sinusitis, exudation processes are prevalent. It's hyperemia, hypostatic swelling, cellular infiltration. And due to stages of pathogenesis, yeah, may be divided to catarrhal, purulent, or necrotic. Also, it may be different types of exudation, as you can see on this picture. Clinical features. Clinical features for all sinusitis are almost the same. Yeah. Firstly, it's maybe headache or face pain. Yeah. Pain localization in maxillary sinusitis will be on the projection of maxillary sinus. Yeah. It may be irradiation to teeth. Eye, forehead, and temple. And chronic sinusitis, the pain can be absent. No, it may be absent also in acute sinusitis. In frontal side, in case of frontal sinusitis, the pain will be in frontal region. Yeah. Ethmoiditis, it's the pain will be in the radix of nasi, internal corner of orbit. And sphenoid sinus, the pain may be very different. It may be irradiate to orbit, it may be temporal zone, parietal zone, occipital zone. So, but more common in the case of sphenoiditis is the pain irradiation to occipital region and in eye. What are the other signs? It's nasal obstruction, nasal cavity discharge, postnasal drip. Postnasal drip, it means that the discharges is passed through the nasopharynx down along posterior wall of pharynx. Also, it may be hyposmia, lacrimation, photophobia, reflex coughing, nasal voice, rhinolalia clouds, temperature increasing, and puffiness of soft tissue of the face, yeah, so swelling of the face. In the case of chronic sinusitis, hypostasis, cellular infiltration, and proliferative phenomenon prevail. Also, exudative and productive forms of chronic sinusitis are distinguished. The inflammatory process are divided on purulent, polypose, and purulent polypose. More often, purulent form is met. So, how to make the diagnosis of sinusitis? Firstly, of course, we start from complaint. Yeah? What complaints a patient with sinusitis may have? You may see on the previous slides. Then it must be, of course, anamnesis with and anamnesis morbid. Anamnesis morbid allow us to suggest what form, yeah, acute or chronic, so how long the symptoms this patient have. After this, we do palpation and percussion, yeah. So in a case of frontal sinusitis, it will be the pain interaction of first branch of trigeminal nerve. In the case of maxillary sinusitis, may be pain in interaction of second branch of trigeminal nerve, and it may be pain during percussion on interaction of these sinuses. Then we provide rhinoscopy, anterior and posterior, or endoscopy. And in rhinoscopy, yes, we may see purulent discharge from the middle nasal meatus. And if it is necessary, you may provide X-ray examination or CT scan. Yeah? X-ray examination, there are two main positions of patients for X-ray. It's the Waters position and Calder-Loop position. And for example, on this picture, you may see the fluid, the level of fluid in right maxillary sinus. It is the main methods of diagnostic, but of course, we may use additional methods. It's diaphanoscopy, thermography, ultrasonic examination, computed tomography, and MRI. And if there are problems, severe problems, we may use sinusoscopy, but sinusoscopy is the more operation techniques, and if you have possibility, you have equipment, instead of anterior and posterior rhinoscopy, you must do endoscopic examination of the nasal cavity. Oh, so it's the CT scan of brain to visualize nasal sinuses. Yes, you can see here the classification of right maxillary or left maxillary sinus. Sometimes we use, but it's more widespread in the context of former Soviet Union, the puncture of maxillary sinus. It's the special needle, Kulikovsky needle, and we use it for draining of maxillary sinus through the inferior nasal meatus. For this purpose, we make local anesthesia, introduce the needle down to inferior nasal turbinate, in inferior nasal meatum, and direct the needle to the lateral angle of eye. In this place, the thickness of wall of maxillary sinus is the smallest, and usually we have no problems to penetrate this wall. So, and also, except diagnostic, it also will be treatment procedure. So, how to treat acute sinusitis? If we're speaking about bacterial sinusitis, of course, it's antibiotics, and indications for antibiotics we will speak about it during classes. So we deassemble the indications for antibiotics during classes, but you must remember that the first line antibiotics are hemosynthetic penicillins, such as amoxicillin, amoxicillin clavulanate. Macrolides, it's the second line, or it is used if the patient has allergy to penicillins. Then the second line is cephalosporins, and the third line is fluoroquinolones. Also, secretalytic drugs may be used, but not all guidelines recommended these drugs. Also, it may be used hypersensibilizing therapy, so antihistamine drugs, but only if this patient has allergy rhinitis as background. Of course, if the patient have pain, feel pain, and he or she has temperature reaction, we may use non-steroid anti-inflammatory drugs such as ibuprofen and paracetamol. And you know that in English-speaking countries for paracetamol we use other term, yeah. Acetaminophen, yeah. So acetaminophen is the same as paracetamol, yeah. Remember, please. And the gold standard for nowadays treatment of sinusitis is intranasal topical corticosteroids, because there are a lot of blind placebo-controlled investigations that show effectivity of this group of drugs in case of sinusitis. Yes. So, frankly speaking, nowadays only 3 drugs, yeah, are mentioned in all recommendations, yeah, in all guidelines. It's antibiotics, non-steroidal anti-inflammatory drugs, and intranasal topical corticosteroids. But if you want to give the patient breathing quicker, yeah, of course you may administer him or her vasoconstrictive nasal drops. Yeah? But remember that prolonged using of these drops may lead to so-called drug-induced rhinitis. So use these drugs not more than 5-7 days as in instruction to these drops. And sometimes you may use physiotherapy also. As we are speaking, the puncture may be used not only as a diagnostic procedure but also as treatment option. But nowadays, in the most developed countries in the world, this procedure is not used. Chronic sinusitis also may be treated as conservative way, so in surgical way. Indications to operation is threat or development of orbital intracranial complications, polypus-form, odontogenous maxillary sinusitis, inefficiency of conservative treatment. Conservative treatment is the same as in the case of acute sinusitis. There are a few operative accesses to paranasal sinuses, but of course, extranasal sinuses are not used nowadays in most cases because it's quite traumatic and it is not physiological, not anatomical. And nowadays, with the development of endoscopic technique, of course, we try to use only intranasal methodics. It's microsurgical when operation microscopes is used, and a functional endoscopic intranasal surgery. It's the gold standard for operation in nose and paranasal sinuses nowadays, because using the optic we may achieve almost any anatomical structures of nose and paranasal sinuses. So, what about complications? Complications of sinusitis may be rhinogenic. They divide into two big groups: orbital and intracranial. Preconditions for rhinogenesis complications become anatomic affinity and neurovascular links. So, of course, yeah, as we see here, ethmoid sinus, maxillary sinus, frontal sinus has very close connection with orbit. Yeah, and of course, the orbit is the first region where complication may be developed. So, ways of infection penetration: it's contact, gematogenous, lymphogenous, and traumatic. No, more common is contact and gematogenous. More often we use so-called Chandler classification of rhinogenous orbital complication. Due to this classification, rhinogenous complications are divided to periorbital cellulitis, preseptal edema, orbital cellulitis, postseptal edema, subperiosteal abscess, abscess of orbit and orbital phlegmon, and sinus cavernosus thrombosis. A few slides later, I explain you what septum is mentioned. This is another classification to Moloney and Grutschur modification. No, as for me, Grutschur modification is the fullest classification, and it includes preseptal complication, cellulitis and abscess, postseptal or subperiosteal phlegmon cellulitis abscess, and postseptal intraconal cellulitis and abscess. And also it may be localized or diffuse. So what septal is mentioned? You see that orbit here is a septum here that localized here, and it is formed by connective tissue. So any complication that is localized externally to this septum, it will be preseptal, and everything which is localized above this septum, it will be postseptal. Yeah, complication. Frequency of orbital complication. It's children. It near half a percent to 15%, in adult from half percent to 8.5%. So you see that in childhood, in children, the complications are more frequent, yeah, because of additional ways for spreading of infection, and because of specific of immune reactive organism, and a lot of fat tissue. Yeah. So what types of orbital complications may be? It may be reactive hypostasis of orbital and palpebralis adipose tissue, maybe diffuse non-purulent inflammation of orbital and palpebral adipose tissue, periostitis, subperiosteal abscess, palpebral abscess, retrobulbar abscess, orbital phlegmon, and thrombosis of orbital adipose tissue veins. And also it may be intracranial complication. Intracranial complications are observed at 1.6% of patients with diseases of nasal cavity and paranasal sinuses. Intracranial complications are divided into extradural abscess. Here it is extradural abscess. No, sorry, it's subdural abscess. Also, it may be extradural abscess, brain abscess, and different of sorts of thrombosis of sinuses, especially cavernous and superior sagittales sinuses. And it may be rhinogenous, of course, sepsis. So any thrombosis of sinuses must be managed as sepsis. About all these forms of abscesses of complications we will speak during our classes, and how to differentiate these forms between each other, and what are a tactic of management of such patients. So for today, it's all information that I wanted you to give. So with my group, we meet in almost an hour and a half, and today we speak about sinusitis more in details. So thank you for attention.